second webinar of Hematology Cancer Consortium. The first one we did on morphology, interpretation of morphology for clinicians. The second one is focusing on immunophenotyping and its basic interpretation for all the clinicians. When we see those reports, when we see those charts, many times, many of us really get puzzled as to how to interpret that. So to address that, we have Dr. Prashant Tembare. He is the Associate Professor in Department of Hematopathology at Tata Memorial Center. Prashant, over to you.
Thank you, madam. Before starting my presentation, I would like to thank Dr. Vikram and Dr. Manju for giving me this opportunity. As the first presentation on morphology is already done, so it is easy to continue with immunophenotyping. And before even starting the session, I would like to thank all of you who already started participating in this session. Because this is little odd time in the afternoon, everybody busy, and I know the clinicians more busy during this time. So I would like to thank all of you who have already joined and who is going to join. So with this, we have 1.5 hour session here, and first 45 to 1 hour, I'm going to have a presentation of different topics and related to the interpretation of flow cytometry, mostly focus on hematology part. And then we are going to have a discussion. But I would like to I would be very happy if you can also ask me any question in between. You can stop me. I think I have no issue with that, and we can discuss that point there also. So we have some freedom in that regard. So so I will start. Okay. So yeah. So outline of my presentation is, so in this presentation, I'm going to cover first a few slides on basics of flow cytometry, because I've been told that there will be few students who are appearing for DM exams. So for them, it is better to understand a better understanding of flow cytometry, how it works. Then the markers which are different used in different hematolymphoid assays, and the main how we approach for the analysis. When we look at the plots, how do we interpret, because our interpretation reflects our reports. And many times you get reports where it shows what is the marker, how it is been represented in the report, either in the percentage form or in the expression form. Or the second is sometimes you can get also dot plots also, especially if the patient is referred from one center to another center. We see the reports with dot plots are given. And as Dr. Manju already said, that sometimes it can be difficult to or challenging for the interpretation. So I would be covering that part also. And then we'll go through some applications, one or two examples with different applications which are commonly used, not because the scope of this topic doesn't include a detailed discussion of any topic or all applications of flow cytometry. So we'll be covering the common applications which we come across routine practice. So coming to the flow cytometry, the flow cytometry, if you look at the word flow cytometry, and if you split it, you can split easily into flow, cyto, and metry. So when you say flow, cyto means cells, metry means measurement. So we are measuring the characteristics of cells, different characteristics, physical characteristics as well as chemical or antigenic characteristics of a cell which is in a flow, which is in a stream. So we study in flow cytometry, we studied single cell at a time, single cell, and we can see a lot of cells which are in the single cell suspension. So basically this is single cell flow cytometry or analysis. If just to show you, these are the different flow cytometers, which these are advanced recent flow cytometers. You might have seen some old flow cytometers. So these are the recent, which are 10 to 13, 14 color flow cytometers. And flow cytometry works on two basic principles. One principle is the measurement of physical property, where we measure size of the cell as well as the complexity of the cells. When I say complexity, prominently I say granularity. Okay. So if you look at in this figure, when a cell come in front of a laser light hit the cell in two areas, one inside the granules and one outside the surface, at the surface. The laser light which come and touch the cell and go in a forward direction, we call it a forward scatter. Now, if the cell size of the cell is small, the scatter of the light which is in forward direction is usually small. But if the size of the cell is large, the scatter is higher, and we can identify the larger cell by using higher forward scatter. The second thing is the granularity, which is present inside the cell. Is my pointer visible to everyone?
Yes, Prashant, it's visible.
Very
Yeah,
perfect.
it's visible.
So when you look at the granules, as these granules also reflect the light in all direction, basically in all direction, 360 degree. But we collect, the flow cytometer collect this light in the 90-degree or from the side of the cell, and hence it's called as a side scatter. Now, higher the side scatter indicates higher number of granules present inside the cell, and lower scatter indicates absence of the granules or very few granules inside the cell. So, for example, if you take a granulocyte or neutrophil which has intermediate size, so the forward scatter will be intermediate size, and because it has granule, so the scatter of the light will be high, hence high side scatter. But if you take a lymphocyte, which will be small in size, so less forward scatter, and because lymphocyte hardly has any granule.
Headphones headphones next time.
So, is that okay?
Yeah,
I
Prashant,
think you're
continue.
fine.
I
Those
think
are
so.
some.
Yeah.
Yeah, I'm
So,
muting everyone.
Yeah. So yeah. So granules. Yeah. So if the lymphocyte doesn't have granules, so it doesn't have any side scatter. So on that basis of just forward scatter and side scatter, we can comfortably separate lymphocytes, monocytes, granulocytes like neutrophil, eosinophils. We can very easily separate. These are called as physical properties. Now the second is the antigenic property. So all cells are made up of different proteins. The proteins are present on the surface, inside the cytoplasm, on the nucleus. So this, for example, in this cartoon, you have different these shapes, which represents antigens present on the cell. When such cell is present, when we analyze the cell with these antigens, what we do is stain these antigen with antibodies specific to these antigens. They are monoclonal antibodies. They are very specific. Okay, and these antibodies are having already fluorochrome attached to them. So these antibodies are fluorochrome attached antibodies. Now, when such cell which has antigen attached to the antibody attached to the fluorochrome come in front of the laser, and when laser hit these cells, actually laser excite these fluorochromes. And when laser excites this fluorochrome, a fluorescence light comes out, and that is been read by the instrument. So basically, each fluorochrome indicates one antigen present on the cell. So if there are 4 colors, that means we have put 4 antigens, 4 fluorochromes. That means we can identify 4 proteins on the cell. If there are 10 color, we can identify 10 proteins on a single cell. If there are 15 color or 16 color, we can identify 16 markers on the cell simultaneously on a single cell. So that is the advantage of this technology, that you can identify or characterize the cells, a single cell with multiple markers. And because the speed of flow cytometry is very high, you can evaluate thousands of cells per second. So we can evaluate thousands of cells per second using flow cytometry and we can analyze multiple markers using multiple antibodies. Okay, and in flow cytometry, we combine both physical and this antigenic property to come to a conclusion and to interpret the data. Now, how do we process the sample? So, as I told you, this is a single cell suspension assay. So we have to have single cells. So we have to make single cell suspension. So any fluid, peripheral blood, bone marrow, body fluid, or even if you have a tissue which we can mince and make into single cell suspension, we can do the flow cytometry analysis. So we routinely do peripheral blood, bone marrow, CSF, peripheral fluid, pleural fluid, ascitic fluid, even the ball. And for tissue also, we can tease the tissue we do FNA from the lymph nodes and flow cytometry on it, as well as we can get the cut tissue, which we mince, and then we can separate the single cells and filter them and use for flow cytometry. Now, for tissue, we need unfixed tissue without fixation of formalin. Okay, so that's how we use separate or form a single cell suspension. Now, in peripheral blood and bone marrow, we also have a lot of RBCs in it. Now, if we want to focus on WBC analysis, for example, leukemia lymphoma analysis, then we don't need RBC. Now, RBC outnumbers the samples to the WBC. The RBC are generally in millions and WBCs are thousand. So it can interfere with our analysis. So what we do, we lyse this RBC by using lysing reagent like ammonium chloride, which lyse the RBC, and then we get just only WBC, which we use for the analysis of flow cytometry. Just to show you this cartoon, if we have a sample, for example, in this we have samples where we have WBC as well as RBC. We put lysing reagent in it. The lysing reagent we incubate for 10 minutes. It lyses the RBC. Then we have only WBCs. What we do is then put the antibodies in it, which are attached to the different flocomes. These are the, for example, antibodies which has different flocomes attached to them, and then we acquire. Now, when we say color flow cytometry, like 4-color flow cytometry, sometimes 6-color, 8-color, you might have heard from your flow cytometrists or pathologists. So what does it mean? So we use different flocomes of different emission wavelength, and they are also excited by different lasers. I'm not going into the detail, but there are different types of flocomes. There are almost more than 28, 30 flocomes available. Usually, the clinical flow cytometry lab 10 to 13 color or 8 to 10 color 8 to 10 flocomes are used. So color means, when we say color means the number of flocomes we can use in our flow cytometer. If I say 8-color flow cytometry, that means 8 flocoms I can put at a time, and I can analyze 8 antigens at a time on a single cell. That means that is how we interpret the color flow cytometry. Now, during analysis, we see different colors. That colors is nothing but just those colors, and these colors are different. Okay, I'll tell you. So that is, so if I say 4-color, that means in a single cell I have put 4 antibodies with 4 different flocomes. But when I say 10-color, that means I put 10 antibodies with 10 different flocomes, and these cells we evaluate in our flow cytometer and analyze them for different markers. So just an example, this is our BMRD 10-color panel where we have 10 antibodies. You can see that 10 different antibodies with 10 different flocomes. So like brilliant violet 510, brilliant violet 421, FITC, PE, APC. These are different flocomes. CD20, CD19, CD10, these are different proteins. So these are the antibodies which are bound to these flocomes. So for example, in this tube, we have 10 antibodies bound to the 10 different flocomes. This is our 16-color AML MRD panel, which we put 16 antibodies with 16 different flocomes. So it allows 16 markers on a single cell, and it helps us to better identify and define a particular cell, whether this is normal or abnormal. Now, how do we start approach and interpretation? So we do the data analysis. So when we acquire this sample on flow cytometer, these all signals from the fluorescence lines are converted into electronic signals. Okay, so basically fluorescence light gives photons, which is type of part of energy, which is these photons are converted into the electrical energy, and this electrical energy, electronic data is then converted into digital analysis, digital data, which we analyze. And we analyze by using different histograms, different dot plots or counter plots. Because this is digital analysis, software analysis, it gives this number of events, percentage of cell, mean fluorescence intensity. So basically, when I say mean fluorescence intensity, means the amount of fluorescence present on the for particular flocome, for particular protein present on the cell, which also directly gives us the amount of the antigen density of that particular antigen. So if CD19 we have MFI, we can calculate the amount of CD19 antigen present on the cell, or for example CD20. So that's how we can identify how many antigens or what is the density of particular antigen present on the cell. These are the different plots. So this is dot plots. You can see there are dots present in this plot. Okay, so these are dot plots. This is a density plot. Density plot means where you see that the color of the plot changes with the density. So yellow color indicates highest density cells, and the brown color indicates lower density cells. The same way you can use contour plot. We generally use dot plots, but we can also use the histograms too. So this is histogram. Here you can see a single parameter. So here you can see one parameter like FITC, and then the number of cells on the y-axis. Okay. So these are the different dot plots or the different plots we use. Now, second term, you might have seen in report gated cells. What is gated cells? Okay, so gate is nothing but it's an electronic window which we have created by using software. Okay, when I say window, it means literally window. So if you look at if you are present inside a room and you have a window, you can see only the area which that window allows you. So that means there is world outside and beside that window, but you can see only the window allows you. The same way, when we put a gate and when we apply that gate to the next plot, we can see only those cells which we have put gated. So if we want to focus on just lymphocyte, we gate the lymphocyte so that the neutrophils or erythroid cells will not interfere with our lymphoid cells. When we get blast, that means we are just focusing on blast and we cannot see other cells. So other cell will not interfere with us, interfere with our analysis of the blast. So that's how we get. So we produce gate, different types of gate. For example, here red you can see this is polygonal gate. In this gate, I have just gated mononuclear cells or particular type of cell. And this is another type of gate. So we can get different cells, we can put different gates as per our convenience, as per our target of cells or our cells of target. Okay, so that is how that is what gate means. Now, if you look at I in the principle, I mentioned forward scatter and side scatter. So if you look at this dot plot here, the y-axis represents side scatter, which means granules present inside the cell, because the granules and the complexity of the cell is scattering the light, and that's why side scatter, which is collected from the side of the cell or the side direction of the cell in the flow cytometer. And forward scatter indicates size of the cell. So here the blue population, if you look at always a dot plot, when if you look at left corner is 0, that means that the signals are weakest or absent. So when the signals are weak or absent, they fall in this part. As the signal intensity increases, it moves away from this 0. Okay, it moves from the away from 0 to 10 to the power 3, 10 to the power 4, to the right side or to the upside. So this is how. So that means the signals are increasing as you are going away from the left side or going away up from the downside. Now in this plot, these plots represent side scatter and forward scatter. So for side scatter indicates granularity and forward scatter indicates size. Here the blue cells are they are closer to this part, that means their size is small. So these represent lymphocytes, and the other reason is because their side scatter is almost nil, it is close to the 0. So they do not have granules. The cells which are small and doesn't have granules are usually lymphoid cells. Then there are the cells which have high forward scatter, this Persian blue color or cyan blue color. You can see the cyan blue color. So this blue color represents a low granularity, because monocytes sometimes have vacuoles and very fine granules, very few and fine granules. They represents the same way. They look like they have little higher side scatter and larger size. So this represents monocytes. Now hairy cells can come in the monocyte area. Many times, if the flow cytometry is not experienced enough, and if we just get on lymphoid cells, they can miss hairy cells, because hairy cells have a lot of cytoplasm, and that's why their size is larger, and they sit generally into the monocyte area. The same way DLB cells, diffuse large B cells, also sit in this area. So depending on the size, that's why the morphology is important, because based on the morphology we know where to get. Or if somebody doesn't have morphology, that cytometrists or pathologists have to look at all areas when they are analyzing, including monocyte area, granulocytic area, as well as this lymphoid area. And these pink color cells nothing but represent the granular cells, that is neutrophils, and in the bone marrow immature granulocytes also. And sometimes eosinophils also we can see here. So basically these green dots represent eosinophils. So that is about the light scatter characteristic of a cell, and simple plain using just side scatter and forward scatter, how we separate. Then this is the same principle which is used laser based cell counters also. So if you take a cell counter which is laser based, which have laser in it, they also use the same principle. Okay. So just an pictorial representation. Now, uh, you have heard LC CD45, which is commonly used in all hematolymphoid malignancy analysis. Now, CD45 is a marker which is present in all WBCs, even early erythroid like pronormoblasts. But as the erythroid cells, immature erythroid cells mature, they lose CD45. There are certain malignancies which are CD45 negative, but for peripheral blood, for basic analysis, we have to understand, because our analysis approach first is based on side scatter, forward scatter, and next commonly based on CD45 side scatter, because CD45 is expressed on all cells, but the intensity of CD45 varies from different cells. For example, CD45 expression is strongest or brightest on lymphocytes and monocytes. Here you can see these are dark blue color are lymphocytes and the cyan blue colors are monocytes. Why did I say that? Because we have seen the same cells in forward scatter were the smallest and side scatter is also their lowest. The pink color are intermediate CD45 and high side scatter, those are granulocytes. The cells which are red color are dim CD45 or weak CD45 and they have low side scatter. This is the area of interest in acute leukemia cases, because the precursor cells or progenitor cells or blast, leukemic blast, normal blast, they all fall here, because the level of CD45 expression is weak in these cells and the side scatter is also low. And NRBCs or erythroid cells or immature erythroid cells, they lose CD45, so they generally lose their CD45 and they fall in this region and they have low side scatter. So the green dots represent these erythroid cells. So, and when we start analysis, we start with the analysis. If we are looking for lymphoma cells, we start with just to show you, these are lymphocytes, monocytes, erythroid cells, blast, and lymphocytes. Okay, so when we start here, this another plot, another way to look at it. So side scatter, generally we look at by linear, using linear scale, and its logical scale. It is nothing but the different type of representation. So when we start analysis, generally in blastic neoplasm, we start with this blast progenitor gate, CD45 progenitor gate, where you can see the red dots. And if we are looking at the lymphocyte or lymphoid, mature lymphoid neoplasm, then we start analysis with CD45 brighter, low side scatter, 45L gate, that is lymphoid gate. Now that doesn't mean we do not look at. A good practice is when we look at all population, because you never know what you see. You can have combination of malignancy, you can miss the malignancy if we just get a small population. So generally in our evaluation, we start based on the morphology or from the one getting strategy, but at the same time we evaluate all cells so that we should not miss any cells or any additional abnormalities. Now this is a list of all common applications. I suppose I need not to go through the all, but what commonly we use is apart from CD4 counting is hematolymphoid neoplasm. Nowadays even the MRD analysis is being used, commonly is being used. PNH diagnosis, MDS, ploidy analysis, post for CD34 enumeration, even antigen quantitation, and recently in COVID situation, like even we have standardized level determination of interleukin 6 or cytokine level quantitation by using flow cytometry. Okay, now in hematolymphoid neoplasm, what is our goal when we look at when we are analyzing flow cytometric analysis? First, we want to look at the identification of lineage. If we have a cells, abnormal cells, what lineage are these? Lymphoid cells, are these myeloid cells? The lineage. Then if we know, okay, these are lymphoid cells, are these mature lymphoid cells, are these immature lymphoid cells? Then if you have like mature lymphoid cells, then third question is, are these abnormal or are these normal? Then fourth question is, okay, even these are abnormal, but whether these are precursor or mature neoplasm. So then the next question is, okay, on that 4 points we know that these are okay, this is immature, this is lymphoid, this is abnormal, okay, either this is lymphoma or this is leukemia, we know that. So that information we get, lineage we know that this is AML. The next question is, what additional information we can get from the flow cytometry? We can do the prognostication of tumor. For example, take a simple example of CLL, CD49D expressing CLLs are poor prognostic, or ZAP70 positive CLL, or there are neoplasms which also indicates abnormality and poor prognosis. For example, CD50, if you have CD117 and CD28 positive myeloma, CD28 positive myeloma is poor prognostic myeloma. So we can gather different prognostic information from the flow cytometry. Then the next way to look at minimal residual disease. Now, many times, if we know that patient is been diagnosed with leukemia and been treated, then we look for minimal residual disease. But many times, patient receive in periphery, especially in from peripheral area, receive already steroids. Okay, now because of steroid, you have small number of cells. So even for diagnosis, sometimes you have to do the sensitive flow cytometry so that you can pick up even the small level of disease for better diagnosis before planning the treatment. Then prognostication and diagnosis of MDS myelodysplastic syndrome, we can diagnose almost 80 to 85% of cases we can diagnose by flow cytometry. And of course, quantitation of antigen. This is mostly used in research parameters, but we can quantitate the antigen. For example, if you want to treat the patient with rituximab, you want to know whether there are enough number of CD20 antigen present or not. The same way, if you want to use nowadays CAR T cell therapy. So if you are using CAR T CD19 CAR T cells, you want to know what is the antigen density of CD19. Daratumab therapy, CD38, level of CD38, because it has been shown above certain level or below certain level, the treatment may not respond properly. The patient may not respond to this therapy. Now, this chart is just for basic, you know, the hematolymphoid cells are divided into myeloid cells and lymphoid cells. And lymphoid cells are further divided into B cells and T cells and NK cells. And myeloid cells are divided into myeloid blasts or granular blasts, monoblast, which is also part of myeloid blast, then megakaryoblast, and rarely erythroid blast. So this is important because these are the origin for different neoplasms. So, and we use the different marker to identify these different cell lineages so that we can identify, we can confirm the nature of disease. Now, when we have leukemia, how do we approach? First our, as I already mentioned, first aim is identify and quantitate the blast. Then assessment of the lineage of the blast. Then confirmation of their abnormal nature, prognostication, and underlying genetic abnormality. So many markers also help you to identify or at least indicate with what kind of abnormality present in this genetic abnormality can be present in this neoplasm. So I'll just show you how we do look at these cells. So when we look at blast, the first approach is to look at low side scatter and weak CD45. Okay, the second approach is to look at immature cells. So here you can see the CD45 negative population, red population, low side scatter indicates one of the feature of the blast. Second is to look at markers of immaturity like CD34, which is a marker of immaturity present on blast only, or TDT. Even in myeloid neoplasm, CD117, HLA-DR sometimes help. So you can see in this there are two plots on the right side. This the red population which are TDT positive, these are the blast population, or the other plot which is down, which are CD45 weak and CD34 is positive. I'm going to come how we interpret positive, weak, strong, because I'm using these terms many times. So in a couple of slides, I'm going to how we interpret the intensity of these. Okay. So these are the markers which we use to identify blastic pulses in mature cells. Then there are different markers which we use for the identification of lineage. So what are these markers? Okay, so for myeloid markers, we usually use CD13, CD33, CD117. We also use CD11B, CD15. These are also myeloid markers. For monocytic lineage, we use markers like CD64, CD11B, CD14. We also use CD36. In fact, CD36 is very helpful marker because it is expressed in 2-3 lineages. Like erythroid lineage, we identify by using CD36, CD235, very specific to the erythroid lineage, CD105. For megakaryocytic lineage or megakaryoblastic lineage, we use CD41, 42, CD61, 62. These are the markers. Commonly, we use CD60, 41, 42, 61, and 36. For dendritic cells, plasmacytoid dendritic cells, like for example, in BPD cells, we use CD123, CD303, CD304. For B cells, we use CD19, CD22, CD20, CD79 alpha, CD10, and also immunoglobulins like surface light chains, kappa and lambda. For T cell, we use CD3, CD1, 2. Basically, if first single digital antibodies are usually used for T cell marker like 1, 2, 3, 4, 5, 6, 7, 8. These are the markers which are easy to remember. And for NK cell, we use 16, 56, CD94, 57. These are the markers which are lineage. But I mentioned lineage associated. The reason I mentioned lineage associated, because they are commonly expressed on these lineages which I have indicated. But in a neoplasm, they can also express in other cells, other lineages also. And these markers are hence therefore also called as a lineage infidelity markers or cross lineage markers. For example, the lymphoid markers which are expressed in myeloid neoplasms are CD7, CD56, CD2, CD5, and CD90. The reason I am telling you, because sometimes if you get inadequate report, it is confusing. CD19 expression doesn't mean B cell lineage always. It can be expressed in myeloid leukemia. The same way, myeloid markers are also expressed in ALL. So for example, if CD13, CD33, 117 is positive, doesn't mean they are AML. They can be expressed in lymphoid like BLL or TLL. So just single one or two marker expression of myeloid or lymphoid does not define lineage. Although their expression indicates that lineage, but they cannot confirm. So for that, WHO has clearly mentioned how do we define or confirm the lineage. And those are called as a lineage defining markers or lineage specific markers. And here are these markers. For myeloid lineage, we have cytoplasmic or cytochemical MPO, that is myeloperoxidase. So if myeloperoxidase is positive by flow cytometry or cytochemistry, then you can confirm myeloid lineage. For monocytic lineage, many times in typical leukemia, MPO may be negative. For that, then we use a combination of two or more markers. Which for cytochemistry, we use non-specific esterase or specific esterases. And and the flow cytometrically, we use the markers like CD11C, CD14, CD64, or CD36. And if more than two markers are present out of these, we confirm this is monocytic lineage. Now, of course, we also consider morphology. If there is clear-cut monocytic morphology, we can confirm that. So that is about myeloid lineage. For T cell lineage, only single marker is enough, that is cytoplasmic or surface CD3 expression. CD3 is highly specific by flow cytometry, but also you have to remember cytoplasmic CD3, because a particular chain of cytoplasmic CD3 is also expressed in NK cells. So cytoplasmic CD3 on IHC or flow cytometry not always means T cells. It can be expressed in NK cells. But because NK cell neoplasms are very rare, we do not consider upfront as an NK cell. Unless and until we exclude first T cell neoplasm, then we consider of NK cell. In addition, with information from NK cells and specific NK cell markers. For B cell lineage, because B cell lineage, there is no single marker. So we have to use a combination of multiple markers like CD19 and CD79A, CD22 and CD10. So when CD19 is strongly expressed or brightly expressed, we need one more additional strong marker. So we need two strong markers. When CD19 is strong, one additional strong marker. And one additional can be CD79A, it can be CD22, it can be CD10. But in some neoplasms, the CD19 may not be strong. In that case, we have to use two other strong markers out of the CD79A, 22 and 10. Generally, CD79A is surface and CD22 is cytoplasm. But because CD22 can also beautifully and nicely express on surface, we usually use surface CD22. So this is a combination. Now, when we say mixed phenotypic, we have to have these lineage defining markers from two different lineages. So if we have myeloid myeloperoxidase as well as cytoplasmic CD3, or the criteria of B lineage is fulfilled, then we say it is a mixed phenotypic leukemia. And rarely we have markers from all three lineages, we call it the triphenotypic leukemia. Okay, now when you sometimes we still sees, unfortunately, we still sees this type of reports from different laboratories. Okay, now that these reports are not totally wrong, but there is a limitation of this marker. You don't know what is the expression level. You see only percentage of particular marker. We stopped this practice after 2012 2013 WHO, because if you look at WHO generally refer to the expression level. As we have seen in lineage defining, we say mention strong or weak. So that's why a standard or good practice is to give the expression level. Somebody is giving in addition to expression level percentage, that is very good, but only percentage is a restricted, limited. It is not wrong, but it is a limited report. So generally when somebody says 79 75% CD13, I don't know whether it is positive in blast or this is present in the, so it has to be very specified. There most of the reports in all standard laboratories, they mention this is about blast only, so that confusion is cleared. But it is a good practice if you also know the expression level. That also helps to, if you are doing MRD monitoring from one lab to another lab, then other lab knows what was the level of 34, so that they are looking for the minimal residual disease monitoring, similar level of expression. Okay. So when we say positive marker, we either call it is negative or positive. When we say positive, we say strong or bright. I'm using the word strong or bright, moderate or intermediate, weak or a dim expression, variable or heterogeneous expression. Especially if you look at the TMH reports, you will see variable report very much. And sometimes we also use partial or subset. What this terminology means? Okay, I'm just highlighting how WHO use. This is the table I'm taking from WHO. You can see they either mention strong word or dim word. You can see dim IgM. You can see weak CD20, or you can see strong CD23, because these are important words and they defines the disease. That's why it is very important to use the expression level instead of using just percentage. So how do you interpret these levels? Just I am showing you. For example, this is our dot plot where we have scale starting from 0 to 10 raised to power 3. This is a logical scale. So 10 raised to 0 means 1, 10 raised to 1 means 10, 10 raised to 2 means 100, and 10 raised to 3 means 1000. So we divide the level of antigen expression or intensity into the logical fashion, and into the and if something is present here between below 10 raised to 1, so we calibrate our instrument in such a way so that all negative population will fall in between below the 10 raised to 1. Now some laboratories can calibrate their instrument where the negative can fall up to 10 raised to 1 or 10 raised to 2. So that depends on laboratory. This is usual practice I'm talking about. So this, if in my laboratory, if I have standardized in such a way that the negative population is falling below 10 raised to 1, then we call it negative. And every interpretation, my interpretation of positive expression is relative to negative expression. So for example, when I say dim or weak expression, that means my intensity or dots are falling close to, very close to the negative. They are, you cannot separate, or they are just barely touching to each other. When generally the level of signals is very close to negative, we call them weak signal or negative signal. Okay. Now this is an example of a plot. You can see here. Here the CD19, this is the gray population indicates negative, and here the blast, for example CD19 was the red population, are almost touching your gray population, which is negative, or it is going below 10 raised to 0, that is 1. I call it CD19 is weak in this population. Okay. Now if we have another population which is almost 1 log different or away from negative population, and it is also equivalent to our normal population. Normal internal control means, for example, if I am taking CD20, our normal B cells usually shows that level of expression, and this expression for us is a moderate expression or intermediate expression. To show you an example here, you can see, yeah, the green population is normal B cells for CD19. So for CD19 on green population, I say these are moderate CD19 positive. But when I say bright, that means which is above the level of moderate expression. So you can see this population is above the level of moderate, and even almost 1.5 to 2 log above the negative population. These are bright expression. And here in the plot, this right side, you can see the bright population, CD19 positive, but their expression level is higher than green population, higher than moderate population, higher than intermediate population. And this is for us bright. So that is how we define the level of expression: dim, intermediate, bright, and negative. And this is all respect to the negative population, negative setup. Now, sometimes we also call partial. So when a population, for example, here the red dots represent blast. Where if you look at 34, a part of blast is 34 positive and part of 34 negative. We call them subset or partial expression. Here you can see the blue population, partial or separate subset expression of particular antigen. And if an antigen is expressing starting from negative to positive, the expression is variable. You cannot say either positive or negative. In that situation, we call them heterogeneous expression or variable expression. And this type of expression are very typical for certain diseases. For example, variable or weak CD20 expression is very typical characteristic feature of CLL. If this CD20 is becomes moderate or bright, it becomes atypical CLL for us. In the same way, if the CD20 is bright or CD19 is bright, that is a typical characteristic feature of hairy cell leukemia, HCL. So that's how it helps us to identify different, not only identify disease, but subclassify the disease. That's why the level of expression is very important when you are defining the disease or when you are characterizing the disease. So this is about the level of expression. And this is our report. For example, this is one of the example prototype of our report where we report all the level of expression in the terms of negative, bright, moderate, and everything. We also report DNA ploidy. You can see the diploid, and we also report CRLF2. I will show you what is CRLF2, and in this we say call positive, as well as we are given percentage, because this marker is defined based on the percentage and not defined on the basis of level of expression. Here we consider if more than 10% blasts are positive for CRF2, then we mention it positive. Or if less than 10%, then we call it negative. So certain markers can be defined based on the percentage. For that marker only you have to mention the percentage. That's it.
So Prashant, I think there is somebody who wants you to repeat the variable, meaning how do you interpret and define variable. So I think that previous slide which you were showing.
So variable. So when you say variable, that means the level of expression is varying intensity. It is starting from negative. Here you can see, because below 10, for example, on x-axis. So I have put this purple on the x-axis. So compare this on x-axis marker. If for x-axis, this part of this is negative and this part is positive, but we cannot say particularly either it is negative or positive. Example is on the right side. If you say the green population, it's starting from 0 and it is going above 10⁻⁴, right? So here you cannot say whether this is just negative, because some of the cells, green population has below 10⁻⁴ or close to the 0, which is in negative area. Some of the cells are in weak area. Okay, some of the cells in moderate or intermediate area. Now, when this type of intensity is there, then we call them variable or heterogeneous intensity.
So as you are
I hope this is
it's perfect. As you're on the same slide, another participant has asked if you can do the same for partial also.
Okay, sure. So I'll go back. So this is partial. You can see here. We can see there are two clusters for this blue population. One is above the 10 to the power 0 and one is below. Now this is the same population. We identify the same population by using different markers. This is tumor. For example, if this is B cells or CD10 positive follicular lymphoma, we are saying, because we have confirmed by using light chain restriction, these all blue cells are tumor. But if we are looking 10, which is partly positive and partly negative, we call partial. Here I am showing an example of leukemia where you can see these all red population dots, red dots represents leukemia, leukemic cell. But when you get 34, 34 is positive in one cluster. You can see there is a nice cluster or the dense population which is 34 positive, but another which is 34 negative because they are all below 34 10 to the power 0, right? So this is called partial expression. So we call them partial. Is that clear?
Perfect.
Or yeah,
Perfect. So let's move. Yeah.
okay. So yeah, so this is I'm showing one case. Now I will take you couple of cases of acute leukemia and how did we interpret it in this leukemia case. Okay, so I'm not going to the history, but you can see these are the blasts. Everybody can see this blast. You can also see there, we can see that if you look carefully, you can spot R rods here. You can see my pointer, you can spot the R rods. Here another R rod. So this is a morphology because our morphology class is already over. It is easy to detect. So these are all blasts. Okay. We have done cytochemistry. This is the routine workup of any acute leukemia, cytochemical stain, that is MPO. Here you can see this is MPO stain. All cells, all blasts are MPO positive, nicely polar positivity. So nice crisp positivity of MPO. So we know these are all myeloid blasts. Okay. Now, when we start an analysis approach, we start with either side scatter and forward scatter based on the mononuclear cell gates, because we know the blast does not have granules, so they all fall with they have low side scatter and their size is intermediate, so they look like red population. You can see the red population represent, the blue population represent the lymphocytes, the green population represent granulocytes. Here with CD45 and side scatter, same population, you can see the red population has CD45 weak expression, which is on the blastic region, and low side scatter. The granulocytes have high side scatter because this is logical scale. It looks like more clustering kind of representation. And we have blue population with lymphocytes with high bright CD45 expression. So in this population, very few monocytes. So we have lymphocytes, these blastic precursors or the precursor or the target population, and we have this granulocytes. Okay, so this is how. So our analysis start with this 45 progenitor gate or blastic gate. So we focus more in the red population because we know we have population which is 45 dim and low side scatter and almost 34%. In normal bone marrow, blasts are usually less than 5%. So if you say if you see 34%, 20%, 10%, that means the precursor cells are increased. Now we have to identify whether these are abnormal and what is their lineage. So we confirm, because based on the 45 we said okay, these are weak. So we confirm with CD34. We know CD34 is the blastic marker. And all these cells are CD34 positive. So you can see the CD34 is positive in this red population. Now we look at different markers lineage. We look at CD19 and 10 and 20 for B cell lineage. In this population, you can see there is the red population also shows CD19, but CD19 is not as strong as normal B cells. You can see there is blue population normal B cells. It is close and attached to the negative population. In fact, the expression level is weak and negative. So we can call it is weak to negative, dim to negative, or heterogeneous expression or variable expression. So this is CD19 is positive, but it is not strong because WHO says if CD19 is strong, you need additional strong B cell marker. But if it is weak, then you have to identify, you have to have either two additional strong markers, B cell markers, to call it B cell lineage. Now just CD19 weak expression indicates that CD19 is positive, but it is not strong enough to call it B cell lineage. So we look at other B cell marker. Other B cell marker include 10 and 20, but those both markers are negative. So one CD10 is already out, CD20 is already out. Okay, now we have only B cell marker. Now we look at other markers, like we look at myeloid markers. So in this population, you can see 34 positive population is also positive for 117, CD117, which is a myeloid marker. It is also positive for CD13 and it is also positive for CD33. This green population, which are granulocytes, they are positive, internal positive control, because 13, 33 both are also positive for this green population, which are granulocytes. So we have blasts which are expressing 3 myeloid marker and 1 B cell marker. Then we look at other markers like T cell monocytic marker like 64, 36. I have not included 14, but it was also negative. Then HLA-DR, which is normally present in blast as well as mature B cell. This is very important. HLA-DR also positive in normal B cells, mature B cells, because it is MHC type 1 molecule. It is present in all antigen presenting cells. Okay, but CD7, which is NK cell and T cell marker, is negative. So T cell markers and NK cells markers are negative. But in next plot, you can see CD56 is nicely positive. Now we have 3 myeloid markers, 1 NK cell marker and 1 B cell marker. Most of you pick up what can be the abnormality, right? So, okay, let's confirm the lineage, because we have MPO is cytoplasmic MPO. MPO was positive already in cytochemistry, or was present. So myeloid lineage was confirmed. Then you have to exclude whether this is mixed phenotypic leukemia, because 19 was positive. So we have seen 19 was weak. So you need 2 additional marker, strong marker. So CD10, which was one of the additional marker, was also negative. And here you can see CD22 and 79 alpha, which are also negative. And just for the confirmation that these markers are working, you can see the normal B cells, like the blue cells, they are nicely positive for 79 alpha and CD22. Nicely positive, indicating that the markers work properly, but they are negative in blast population. That is red population, and MPO is positive. Even the cytoplasmic CD3, that T cell marker, is also negative. So hence we confirm that this is myeloid leukemia with aberrant expression of 19 and 56, which indicates an abnormality, underlying cytogenetic abnormality, that is AML with translocation 821, or now RUNX1 T1 translocation or fusion. So not only we identified the blast by using 34 and CD45, we confirm the lineage by using different markers, and then we confirm the underlying cytogenetic abnormalities, that is presence of CD19 and 56 typically is seen associated with AML with translocation 821. So we confirm. So in our report, we advise for the cytogenetic guys that this is it most likely 821 positive AML. So please also include your probes for CD8 means 821 translocation. And the same phenotype we also use for minimal residual disease. I will go to the minimal residual disease, but in this case, post-induction MRD, you can see these blasts were 56 and 34 positive, and these blasts were just 0.045% level. So we can identify using this expression. We also confirm, we also monitor the residual disease present in this case. Now, next case, this you can see there are number of blasts and there are some lymphocytes, and these blasts are MPO negative. Okay, the blasts morphologically look lymphoid because they are small, but we have to confirm because many times the morphology overlap with the different lineages and different research. So it's not confirmatory. Although you have a hint where good morphologists can indicate this is ALF, but we need to confirm. So for confirmation, you need flow cytometry or immunohistochemistry, as well as for monitoring also you need it. Now, and then prognostication. So in this case, I'm just showing the flow cytometry different example. Just there are 15% blast which are CD19 positive. Now here you can see CD19 is brightly expressed, strong expression. They are CD34 positive, right? So one strong criteria of CD19 is fulfilled, but at the same time, the CD10 is negative. So another criteria we did not fulfill of CD10. So we have to look for CD79A as well as CD22 to confirm the B cell lineage, or it can be another leukemia which just CD19 positivity. Okay, so the other plot you can see The other myeloid markers are CD15 and L11B we have done in this case, but the red population just shows CD15, not L11B. Now CD15 is a myeloid marker. So we have CD19, which is strong, which is a B cell marker, and CD15, which is a myeloid marker. Now this is not, the lineage is not confirmed in this. So we look other additional markers where we look cytoplasmic CD22. You can see the CD22 is positive, but it is not strong as like normal B cell. It is positive, but it is weak and heterogeneously positive. So you need something which is strong. And the next plot you can see CD79A is nicely positive, strongly positive, because it is cytoplasmic 79A. The strong expression comes to here only. It never goes above that. Even the lymphocyte are the same level. So you have CD79 strong, CD19 strong. So B cell lineage confirmed. And at the same time, MPO is negative and cytoplasmic CD3 is negative. So myeloid lineage is excluded. So we have B cell lineage, BLL, which is CD10 negative and CD15 positive. So many of you already pick up what is the underlying cytogenetic abnormality in this case, right? Now we have one specific marker which is very specific to this abnormality, that is called as NG2. By flow cytometry, just putting one additional marker, we can confirm this cytogenetic abnormality. So in this case, NG2 was positive, and the cytogenetic abnormality is nothing but BLL with MLL gene rearrangement. So when you have MLL for translocase 411, the typical phenotype of BLL is absence of CD10, which is also called as pro-BLL phenotype, and presence of CD50, and very specific, highly specific marker. Even sometimes fish can miss this entity, and if you pick up by RNA-seq, we have a couple of cases which pick up by RNA-seq and just flow cytometry. Example. Now, coming to the next entity, which we have heard for last few years, last 5 years, 10 years, we are looking at is pH-like BLL. Now, these are the common aberrances which are seen. I am not going into detail of pH-like BLL, but I would like to highlight the CRF2 rearrangements or mutations or fusions with the commonest abnormality present in pH-like ALL. Almost 50 to 60% of pH-like ALL present with this, and fortunately, we can pick up this all abnormality by flow cytometry very easily, because we have to just put one marker of one antibody for CRF2, just one, which costs generally 100 rupees or to 200 rupees for a flow cytometry lab, in addition to your routine flow cytometry, and you can pick up 50 to 60% of pH like ALL out of total. The other methods to pick up is fish as well as molecular. Okay. So these are the additional abnormality. I am going to show you the example. For example, in this BLL, which is 45 negative, 19 positive, and 10 positive. Okay, and here you can see they are TSLPR positive. So this is CRF2, which is positive. Okay, so I think I'm completing 1 hour. So I'm little moving fast to the mixed phenotypic acute leukemia, and I'll be touching a couple of other assays, which also will be covered. Generally, we use by flow cytometry. So this is another case where you have myeloid markers and T cell marker, that is CD7 and 2. So myeloid and T cell markers. And if you look at cytoplasmic MPO and cytoplasmic CD3, both were positive. So when both cytoplasmic and lineage specific markers are positive, then we call it T myeloid marker. We also do the DNA ploidy. I'll just show you the example of DNA ploidy. Here you can see what we do is calculate the DNA index. So we have a DNA dye called an FX cycle violet. Earlier we used to use the other dye like PI, propydiamidine. It binds to the amount of DNA. So amount of DNA present in a cell indicates the amount of fluorescence. If you have 60 chromosomes, the DNA will be, the fluorescence will be higher than 46 chromosomes. If you have 35 chromosomes or 36 chromosomes, the amount of DNA binding dye will be less. So less amount indicates hypodiploidy, higher amount indicates hyperdiploidy. Same amount that of like normal cells indicates diploidy. For example, here the blue cell population indicates lymphocytes, that is 46 chromosomes, and red population of blasts. In this case, both peak are overlapping with each other. That means the amount of DNA binding dye is same, indicates diploidy. Now the next case you can see this is hypodiploidy, because you can see the amount of dye is lesser in G1 phase as compared to the blue cells. This shift to the left. This indicates hypodiploidy. And if you have amount of dye higher, that is shift to the right, indicates hyperdiploidy. So these are the different markers which indicates underlying cytogenetic abnormality. For example, CD25 positive BLL usually indicates pH positive BLL or pH like ALL. Okay, so almost 90% correlation. If you have 10 positive, 15, 10 negative, 15 positive, but Ng2 positive, MLL gene are in. CRF2 positive, pH like ALL. If DNA index for practical purpose less than 0.88, we take hypodiploid, and DNA index more than 1.16, we take hyperdiploid. Same way, AML, if 19 and 56 is positive, indicates 821 translocation. A typical phenotype that is high side scatter, the 3044 negative, DR negative, 18 negative indicates APML. If you are Ng2 positive, translocation 911, that is KM2A translocation mutation. CD25 positive, 34 positive, 123 positive AML blasts correlate highly with FLT3 ITD mutation. CD2 expressing blasts correlate with inversion 16 or translocation 66. So these are just typical examples of correlation with this. Now, one question practically you always feel that in flow cytometry and morphology, you have discrepancy in the blast percent. And there are reasons. If the blast percentage in flow cytometry less than the manual count, that is morphology, these are the reasons. Possibly the sample which is run for flow cytometry is dilute, or there are clots, or there's some blast which may not, which morphologically look like blast, but by flow cytometry, somebody just using by 34 and 117 may not get, or CD45 expression. Sometimes, rarely, the other way around can happen, that manually you get less, but flow by flow it is higher. The reason might be you are losing some cells like NRBCs or WBCs, neutrophils, if you are using 5-call based preparation. Okay, or sometimes morphologically it becomes subjective, or the morphology slide is not good, staining quality is not good. You seeing there are blasts very few, but by flow cytometry you can have higher number of blasts. This happens when the percentage of blasts are less than 20%. Then the morphologically usually you count less because you are counting just 200 or 500 cells, but by flow cytometry you can get more accurate count. Just couple of lines on how minimal residual disease. So residual disease, if you look at when you have at the time of diagnosis blast, you have a lot of blasts. Okay, when you give chemotherapy, most of the blasts disappear, but very few blasts remains. And this blast, which we do not pick up by morphology, but need ancillary technique like flow cytometry, molecular, these are called this is called as a residual disease, and these are generally the responsible for the relapse of the disease. Okay, and we calculate identify residual disease based on the principle that there is expression pattern is abnormal on this blast, okay, as compared to the normal immature cells, or if there is aberrant antigen expression. For example, normal myeloid blast will not express bright expression of CD56 or CD2. So if that is present, that means that is abnormal. So we identify that. So for that, we have to check, we evaluate normal precursors, normal B cell precursor, that is hematogone. So for example, these are the normal hematogones, okay, which usually 10, 45, 10, 20, and 10, 34. They all, no matter where you go in whatever country, all humans shows the normal maturation pattern of hematogone. Using this knowledge, we form a gate, okay, because they shows typical maturation pattern, we form gates. So all B cell precursor, normal B cell precursor fall in this. But if a population which looks immature but falling outside this gate indicates asynchronous expression of these markers, deviation from normal maturation pattern, and that means these are abnormal cells, that means these are abnormal residual disease. Just to show you, the plots which are on the lower row, they are not falling or gate, they are falling outside. For example, here CD10 and 73, they are outside the gate. This indicates the residual disease. Even at the time of diagnosis, they were at the outside. So above row indicates diagnosis, the below row indicates that the residual disease. So you can see they were outside. 73 was overexpressed or strongly expressed. 86 or overexpressed and strongly expressed. So here you can see These blasts were outside the gate as compared to the normal, indicating residual disease. We can identify, we can standardize high sensitivity assay. We have standardized in TMH, where we can identify 2 in 1 million cells. So 0.0002 we can go. This is practically equivalent to any molecular based data. So we can identify, we have published this data also. So by flow cytometry, by acquiring millions of cells, we can achieve very high sensitivity of residual disease. This is just an example. Now, I don't know whether I should go for lymphoid population because I have crossed 1 hour already. I would ask Dr. Manju if I should continue because it will take 15 more minutes, or I can skip these slides and I go to the conclusion.
I think Prashant. Sorry,
Yeah,
go ahead, Manju.
Go ahead, Vikram. No, go ahead, Vikram.
I think we can go ahead for a little while. It's going very nicely, Prashant.
Yeah, sure.
So another 10, 12 minutes should be fine.
Yeah, okay. So I'll move. Go ahead. Yeah. So mature lymphoid neoplasm. So how we proceed with mature lymphoid neoplasm? We have seen how we proceed with immature. We look for CD45D and markers of immaturity. In mature, we look for other way. So 45 bright or strongly expressed are basically mature cells because CD45 density increases as the cells mature during the course of maturation. Or absence of markers of immaturity. For example, 34 is absent, TDT is negative, that is immature. That is the mature cells, mature malignancy arising from mature cells. And we also look for light chain expression like kappa, lambda, and we can look for the markers of maturity in T cell. For example, T cell, cytoplasmic CD3 indicates immature and surface CD3 indicates mature T cell. Okay, so that's how we look at. Now, for typically, just I'm showing an example. Here you can see these are the 19 and 20 positive B cells, but if you look at CD45, they are mature. They are not falling into the immature gate, which indicates that these cells are mature. Other feature is CD20s. Generally, usually, not all, usually CD20 is dim to negative in or weak to negative in BLL. But there are some BLL which are also CD20 bright positive, which usually can respond to rituximab. Okay, so that is but usually CD20 is brightly expressed in lymphoma, B cell lymphoma, except CLL where you can have weak expression of CD20, or there is rarely in what is called as a double hit lymphoma, you can have CD20D. And third common scenario nowadays is if patient has already taken rituximab therapy. So if the patient has taken rituximab therapy, CD20 can be upset. If there are 3-4 months gap, then there will be weak. Generally, CD20 comes to normal level after a period of 6 months of stopping antibody therapy, usually. Okay, so that's how we start. Then we look at the clonality. So here you can see there are in this gate, the red population indicates abnormal and blue population indicates normal. Normal population, you can see clearly they are polyclonal because they are expressing both kappa and lambda. So the blue dots present on the kappa side are kappa positive. The blue dots present on the lambda side are lambda positive. But the red population only present on the lambda side, kappa side, sorry. So that means they are kappa restricted clonal population. That's how we identify clonal population. Then we also look at abnormal expression. For example, in this plot, these are all B cells. They are 20 positive, but they are also CD5 positive. Normally, very small population of B cell express CD5, which are naive B cells. But if you have huge number of B cell population, which is clonal and CD5 positive, they are also aberrant. So the other way to look at abnormal B cells is to look at aberrant expression of CD5 or CD11C or CD103 or CD25. Like in hairy cell leukemia, CD10 in follicular lymphoma, CD10 also in Burkitt lymphoma. So these are the different lymphomas we look. Okay. Now I am going to an algorithm which we generally use for the classification of B cell lymphoma. We look for once CD10 and 19 is positive and 45 is bright, we confirm that these are mature B cells. We look for CD5 expression. If CD5 is positive, next marker we look CD200. Now CD5 and CD200 both are, if CD5 and CD200 is positive and CD20 is dim, then it is a typical case of CLL. Also we use CD23 for CD200. So CD23 and 200 go simultaneously. Only advantage is CD23 can be variably expressed in other B cell lymphoma. So that's why specifically mantle cell lymphoma. So we prefer CD200, but CD23 is historically used. So CD5 positive, 200 positive, CD20 dim, typical CLL. If CD20 is moderate or bright, it is atypical CLL. At least immunophenotypically, it is atypical CLL and may respond good to rituximab. May. Okay, but you are the best judge. Now, if CD5 is positive but 200 is negative and 20 is moderate, this we label it mantle cell lymphoma because there are many studies which has confirmed CD200 negative, CD5 positive, moderate 20 is very typical features of mantle cell lymphoma. Also remember, you can have 5% of other NHLs can be CD5 positive. For example, SMZL or DLBCL or can be positive for CD5. CD5 positivity can show CD5 positive, but generally very small population. Now, if you have CD5 negative, then we look for what's next for marker. We look for classification is CD10. If CD10 is positive and low forward scatter, because remember forward scatter indicates size. If small size indicates small cells, and if CD38 dim to negative, it usually go with follicular lymphoma. So follicular lymphoma small cells and 10 positive. Even CD10 is weak or negative, very weak to negative or heterogeneous. But if you have high forward scatter, indicate large cells, which indicate large B cell lymphoma, that is which correlate with DLBCL. And CD10 positive DLBCL usually means germinal center B cell lymphoma. Now, if you have cells which are large, but CD38 is bright, 10 is bright, 81 is bright, and typical morphology, blastic morphology indicates Burkitt lymphoma. That's how we Burkitt. We look for the Burkitt lymphoma. Now, if you have CD10 negative, CD5 negative, but high side scatter, large cells, the B cells, and we have BCL6 positive, but MUM1 is negative, again, GCB type of B cell lymphoma. But BCL6 negative and MUM1 is positive, ACB type of lymphoma, ABC type of lymphoma, activated B cell type of lymphoma. Okay. Also, we can look at Ki67 by flow cytometry. In DLBCL, it is higher that's compared to the low grade B cell lymphoma. So this is we proceed. This is how we proceed.
So,
but if we
Prashant, just if you can go back to the slide before this, the one before this, yeah. They wanted, so I think two people have asked if you can just flash the final slide. You don't need to.
This is the final slide. Yeah. So 5 positive, 200 positive, 20 dim or weak CLL, 5 positive, 200 positive, 20 nicely positive, moderate or bright, or typical CLL. If 5 positive, 200 negative, but 20 positive, mantle cell lymphoma. You can confirm with cyclin D1 by IHC. Okay. I'm moving to the next slide.
Yeah, great.
Next slide also, I'm just repeating. If 10 is positive, small cells, that is low, forward scatter is low, and 38 is usually dim or negative, follicular lymphoma. If forward scatter is high, large cells indicates large B cell lymphoma. And if 38, very typically 38 is bright, 10 bright, even the additional marker like CD81 is bright, and morphology is typical, like because blastic morphology, Burkitt lymphoma. And if 10 is negative and still high forward scatter, large cells, and then you look at MUM1, you can easily, we can do MUM1, we do by flow cytometry as well as IHC, because it is surface marker, it can be easily done. MUM1 or BCL6 is difficult to standardize, but can be standardized. So you can do, or we always easily done by IHC. So that is different types of DLBC. Now coming to the, if we have both negative 5 and 10 negative, then what we do? Then we look for the other markers like 11C, CD103, CD305. CD305 is a relatively new marker. And if 11C is brightly positive, CD103 is also positive, and 25 is positive, CD25. So there is a triad, 11C, 103, 25. This is classical hairy cell leukemia. But if CD25 is negative, that is hairy cell leukemia variant. Classical hairy cell leukemia, morphologically deficient in monocytes. Monocytopenia is there, present with low counts, pancytopenia. Hairy cell variant present with very high count and 25 is negative. And very typical morphology, prominent nucleoli by morphology. Morphology is covered, so I'm just repeating it. But if you do not have these markers also, then we look for, then it becomes little tricky. Then we look at CD IgM positive. If a CD IgM is, sorry, not CD IgM, IgM is brightly expressed Then we ask to look at IgM, the M protein, to look at if there is M protein, because then it indicates Waldenstrom and lymphoplasmatic lymphoma, or confirmation by molecular by doing MYD88 L265 mutation. Or if IgM is not brightly positive, remember IgM is also brightly positive in mantle cell lymphoma, but it is not differential diagnosis here because it is always CD5 positive. Now, if say IgM is also not positive, we have new marker which we have evaluated recently for last 2 years. If CD180 is brightly positive, it indicates marginal zone lymphoma because CD180 is expressed on marginal zone cells. So that is, and the patient has splenomegaly, there is splenic marginal zone lymphoma. If has lymphadenopathy, then possibly nodal marginal lymphoma. This is the track we follow, but we always correlate with histopathology and cytogenetics for final impression. Okay, now just I'm showing one example. This is a lymph node tissue. We have received lymph node tissue, so we have directly processed lymph node tissue, not even FNA. You can see these all are small cells, no neutrophils because lymph node tissue, no blood contamination. Okay, and they all are 45 bright, no precursor cells. Okay, so when we confirm, they are all 19 positive. Here you can see, and 5 negative. But they are all at 10 positive. You can see the 10 is heterogeneous variable expression starting from moderate to negative. So 20 positive, 19 positive, 10 variable small cells, and they are all 10 positive, and they are all are lambda positive. Okay. When we have done BCL2, they are all BCL2 positive. This is done by flow, so we standardize the flow, but it is difficult for standardization. And BCL6 positive. So hence we confirm that this is a case of follicular lymphoma, small size, BCL6, BCL2 positive, 10 positive, everything. So this is how we confirm that this one is done. In myeloma, possibly I will skip the myeloma because rarely people do, but just for revision, I'll take myeloma. We isolate the cells or get the cell by using CD38 and 138, and then we look different markers, 19, 27, 56, and 45. Normally 19 positive, normal plasma cells are 19 positive, 27 positive, 81 positive, 45 moderately expressed, and in abnormal cells 19 is negative, 45 is negative, 27 negative, 81 negative, and they express aberrantly. 56 is commonest, followed by 117, 28, and 20. Just an example, I'll show this, and they are cytoplasmic kappa restricted, lambda restricted. Now, T cell lymphoma also we have the approach. We look for the pan T cell markers. For example, CD2, 3, 5, 7. These are pan T cell markers because they are present in all T cells. In T cell lymphoma, they shows aberrantly bright expression or loss, that is weak expression. The loss is common. And then once we confirm there is loss, indicating there is abnormal T cells, then we look for the CD4 and 8 because maximum T cell lymphoma CD4 positive or 8 positive, and the rest of 4 and 8 double positive and negative. So only CD4 positive indicates abnormality, only CD8 positive indicates abnormality, positive both expression indicate abnormality, and negative both expression indicates abnormality. But T cell lymphoma is rare and need better experience for it. Now we can also do the clonality establishment. The clonality by flow cytometry is done by either TCR V beta reporter, which is complex, need extensive assay. We do. But now, last 2 years, there is another marker which is single marker analysis, which is very few probably people know, that is called a T cell receptor B constant chain 1, and it is equivalent to kappa or lambda. So one marker, if we are kappa restricted, either kappa will be positive or kappa will be, if we have clonal B cells, either kappa will be positive or kappa will be negative. Kappa negative means lambda positive, right? So using the same principle, if you TCR B1 positive, all cells are only TCR B1 positive, indicates clonal. All T cells are TCR B1 negative, indicates clonal. Because normally half of them are positive and half of them are negative. Like normally B cells kappa are positive, half of them are positive and half of them are negative, same way. Just I'll show you. These are normal T cells. TCR B1, half of them are positive, half of them are negative. These are normal polyclonal T cells. But if you have clonal T cells, they all will be TCR1 positive. More than 90% are they positive, and very few cells are negative. Clearly indicates clonality. Very easy single cell marker, easily done flow cytometry surface. So T cell clonality no more. It's complex or challenging by flow cytometry. Or if they are completely negative, you can see they are completely negative. So in combination with aberrant expression of pan T cell marker and TRBC1, you can confirm the T cell clonality also. Maybe I'll skip MDS, I guess. I'll just skip because this is little complex. Now PNH is different, something different, which PNH you usually see. Now PNH, up till now we are looking at abnormal positive expression. In PNH it is abnormal negative expression. We know the PNH is a defaulted GPI anchor protein abnormality, right? So the protein which is due to this aberrancy, the protein which are GPI anchored, GPI protein anchored proteins are actually absent because the link is missing, anchor protein is missing. So missing, something is missing is abnormality, right? Now this is just how it works. What are the abnormal markers or the anchor proteins we commonly use? There are a big list of GPI anchor proteins, but these are the common. For RBC we use CD55 and 59. And for WBC, we use CD14, 16, 157, 177, but FLAIR is the commonest used. What is FLAIR? FLAIR is basically a fluorescent, this is a fluorescently labeled toxin, aerolizing toxin derived from bacteria. Okay, so this toxin generally, if the GPI link is maintained or GPI proteins are present, it will go and bind to the GPI proteins. But in the absence, in PNH, it cannot bind. So if the protein is not binding, that means there is aberrancy. If the protein is binding, that means there is no aberrancy. I'll just show you recently. This is RBC. So RBC, you can see the normal RBC should be 59 positive. The abnormal will be loss and negative. This is I'll show you one recent example we got in our hospital for the transplant, and this is the example. This is normal. You can see normal granulocyte or 16 positive, FLAIR positive, monocytes 14 positive, FLAIR positive, and even lymphocytes, very few other exception for few cells, degenerating few cells, 45 positive and FLAIR positive. Okay, so these are normal. Now what happens in PNH? You can see a 94% of clone is FLAIR negative and 16 negative. Both markers are negative. Even the monocyte 14 negative and FLAIR negative, and lymphocytes also variably negative. So because the four monocytes and granulocytes are best evaluated and give the best quantitation of FLAIR clone, the PNH clone, they are used. Because RBC you cannot use once you have transfusion. If the patient receives multiple transfusion, you have normal RBCs, so it cannot represent the disease level of disease present. But because WBC generally does not contaminate after transfusion, so WBC is the best judge. And the second is, it has been shown that it is very sensitive. You can pick up almost up to 0.5% of PNH clone by using WBC. Next is quantitation of cells, like CD4 counting. What we use, we put beads by using single platform. So what we do, we put beads. So if, for example, if we put 5,000 beads in 5 microliter of sample, that means 1,000 bead represents 1 microliter of sample. Then we count the number of CD4 positive cells per 1,000 beads. So for example, if I have 500 CD4 positive T cells per 1,000 beads, that means the 500 CD4 positive T cells per microliter. That's how we count. But it can vary from lab to lab because number of beads they are putting in the per microliter sample can vary. In our laboratory, we put, for example, 900. Then we have to calculate like that. The same way we use CD34 counting also. CD34 we count and number of beads per microliter we have. So we count the number of CD34 positive cells in per beads, and then we calculate the number of CD34 cells in per microliter of the sample. That's we count. Then also now recently, this is my last couple of slides. Recently what we have done, we have seen in COVID situation, interleukin 6 got very much importance. In fact, cytokine, but interleukins particularly. Now we evaluate by ELISA, but ELISA is not everywhere available. So we can also do by flow cytometry. We have standardized in our lab. So flow cytometry, what we do, we can do is called as a cytokine bead array or cytometric bead array. There you have a bead which has antibody attached to it. That antibody will bind to the particular soluble protein, for example, interleukin 6. And we put another antibody which is attached to the fluorochrome. So what will happen? This bead will bind to from one side bind to the protein, and another bead with fluorochrome bind to the other side. And when these beads come in front of the laser, it can count the fluorochrome and thereby count the soluble proteins. Right. So that's how we calculate. And we have different types of beads for different cytokines. For example, here we calculate 6 cytokines. We plot a normal curve standard by using standards, and then we quantitate. I won't go into the details because it's a little complex and time consuming. But the idea is that using bead assay, you can also count cytobead as these soluble proteins. Now coming to the last couple of slides, what are the advantage of this technique? One is it is single cell analysis. You can do functional analysis, like what is the cytokine expression, cytointerleukin secretion, proliferation. Qualitative analysis, what type of cells are there? Quantitative, what is the percentage of cells? We can use both liquid and solid. Only thing is, for a solid tissue, you have to use unfixed cells, you have to tease them, and nowadays you get a machine which can quantify the cells. For even if you want to look at the immune cells from lung tissue or kidney tissue, you can separate the cells and you can do that research. Then it is very high throughput because you can do 5 to 10,000 cells per second. So it is single cell proteomics basically, and you can go up to 28 color. Clinical laboratories can go up to 16, but in research laboratory it can go to 28 laboratory colors. Very rapid. You can get the result 2 to 3 hours. Okay, when I say 2 to 3 hours, you will say, then why do we get results after 2-3 days? The reason is, if you have lot of samples and lot of cases, then you have to look all them and collect reports them together. That's why sometimes you have to put additional markers to characterize properly, and so it takes time that way. But if you want to just give a single report, straightforward case, you can detect give the report in 2-3 hours. Then it is highly sensitive. We are seeing you can go up to 2 to 1 million cells. It can detect simultaneously cytoplasmic, surface, nuclear markers. It also gives indirect or direct evidence of genetic abnormalities. It is highly reproducible. That's why there are thousands of flow cytometry labs. In India, more than hundreds or 200 labs are there. It is cost effective, rapid, readily available many center, and also using the same principle, you can sort the cells and do the research. Now there are limitations you have to know. One, you cannot, because you are looking at single cells, you cannot look at the architecture of cell like histopathology in IHC. So no architecture. You can look at the size but not architecture. Then you need fresh sample. Generally, the good results you get if you process the sample less than within 48 hours or maximum 72 hours. If we get sample more than that, if it is a precious sample like bone marrow or CSF, we still process, but there is no guarantee you will get good results. Okay. In an emergency situation, we can freeze the cells at -80 and then process the sample, but the freezing need to standardize the protocol of freezing. Then cannot be performed on fixed cells, like you have block and you cannot do flow on it. You know, if some people have tried for ploidy, you can get the result, but they are not that reliable. Many times the cells are dead. You cannot use the formalin fixed cells, because many times what happens, the protein the protein structure altered because of formalin, and you do not get good results. Then you need adequate training. So all flow cytometry labs and technicians, I'm repeating technicians, they're well trained. For technician, at least 6 months training, and for pathologists also need 6 months training. If they want to do like IHC kind of training, they have to have 1 year training in a good busy laboratory. There are many busy laboratories, Tata Hospital, AIMS, PGI, CMC, Vellore, where you can get training and then start. And currently, we do not have direct evidence other than a couple of like CRF2, or we have this one. But there are flow cytometry like RNA flow, which is already standardized, or fish flow, for example, for BCR, APM. The papers have been published, but not in clinical practice. But these are the genetic limitations. These are the limitations. I think I've concluded here. So thanks. I think we can discuss if we have any questions.
Thanks, Prashant. That was wonderful. Meaning, I learn each time when I hear you talking about immunophenotyping something new.
Thank you. Thank you.
So just we'll take a couple of questions. You've answered most of them in your talk. I just will try and focus. And people who have asked the MRD question, I just want to tell you that please come back for the MRD session. Prashant is going to be back for our MRD class again. So I'm just going to keep those questions limited. Many people have asked a question on how you quantify the expression, which you've already taken. There's some very basic questions like, if you're sending the tissue for flow cytometry, what is the best way to send it?
Yeah.
So that's something which is.
Yeah. So if you have tissue, for example, your lymph node tissue, even the true cut biopsy, core needle biopsy, needle core biopsy you have. what you have to do, it is good to communicate laboratory first, because then they can guide best way. So for example, if we communicate with us, we provide you the RPMI media. If it is coming, for example, if the tissue transport is taking more than 6 hours, it is best to send the sample in RPMI media, because it maintains the cell viability. If it is not maintained, then it is very difficult. Then you may not get optimum results. If you are sending within, like if you are inside the hospital, then even the normal saline is suffice within 2 hours if you are doing that. But for delayed transportation, RPMI media is there. There are other medias also available, commercial medias, but RPM media, many laboratories use, all flow cytometry laboratories have RPM media, almost all. So they can provide you in advance if you are planning to send the tissue.
Great. So I think while we are on the sample collection, there's one more question between EDTA and heparin sample. Is there any added advantage for one over the other for flow cytometry?
Yeah. So for flow cytometry, you see, generally, if you look at go through the literature and very experience, heparin is best considered. The reason is because the viability is maintained 12 or 12 to 24 extra hours than compared to EDT. But the second limitation of heparin is when you prepare the smears from the samples, you get high bluish background. So the interpretation becomes difficult. Now it is it is a good practice for a laboratory to make the smears before they may giving the panel, because it gives you always an advantage of looking at morphology, cell count. Sometimes the cells, you see large number of cells. I'll show you an example. We have a case of ALCL, morphologically it was involved. By flow cytometry, by routing approach, we were not picking up, okay, because those cells were all falling into the high side scatter granulocytic area. Now, but because we knew that there are abnormal cells, then we start looking all areas to identify those cells using combination of markers. So it gives advantage. So it is a good practice to make smears from the samples which has been sent to your laboratory, and then look into. Or if you are, or the other way, for clinician, it is important if you can make smears on the spot and send unstained dried smears. Please do not send fixed smears, because those give staining background. Methanol fixed cells smears or ethanol fixed smears gives very big, means high blue background. So your air dried smears are well fixed. So if you spend air dried smear well packed, that will help. So if you're sending slides along with then heparin sample, then that is best.
Okay.
So, but EDTA works very well for flow cytometry.
Great. So there is a question that you were talking about, dim, moderate, bright expression. So let's say if there are no comparable cells, and the example given is that if there are no normal B cells in case of BALL, how would you differentiate between dim, moderate, and bright expression?
Yeah, I think this is excellent question. So what we do in flow cytometry laboratory, something which any laboratory or any practice, for example, is called as standardization. So what we do is we standardize. When we say standardize, means we run tens of samples, 20 sample, 40 sample, normal samples, where we define the gates. So we put a gate for normal samples. So normally we should have B cell in this gate. Normal 20 expressions should fall here. Normal 34 expressions should fall here. Normal TDT expressions should fall here. So we already predefine gate based on the normal cells. Now, if I get a sample which doesn't have normal cells, but we know that this is the normal reference gate. So on that basis, we can compare. If the cells, for example, 20 is falling in the normal gate, the gate I have defined based on the normal, that means the expression level is intermediate. If or moderate. If the level of expression is below the normal gate, then that is weak. If it is above the normal gate, then it is bright. So even if you do, many times you don't have, that is the real practical question. You don't have normal cells, but because we have standardized our template, analysis template on the basis using normal samples, we can easily correlate with them. And it also gives other advantage that if something wrong with our flow cytometer, for example, there can be normal cells, right? But our flow cytometer is not properly working. So, or technologist forgot to put CD20. He'll say it is negative. No, it is not negative. So when we look into the normal gate, is it falling? Normal B cells are falling in normal gate or not? If the normal B cells are not falling in a normal gate, that means there is something wrong with antibody adding or instrument problem. So we can pick up not only instrument, antibody cocktail, but also it gives us a reference level. So we always advise to make a template standardize it, and use them as a reference analysis for the reference analysis.
Great. So I think there are two questions which are almost very similar. Should the lab report percentage as well as intensity of expression? Because apparently some clinicians do insist in terms of percentage. So
Okay.
is there, so what
Yeah,
should
so
we?
see, ideally, if you ask me, it is best to have communication with your clinician. Why they want percentage, you have to know. All right. Sometimes historically, if you look at the people they are used to percentage. That's why they possibly they are asking for. But you have to educate everyone, your clinicians also, that this is the way they report it. But if they insist, it is good idea to give both. Just giving percentage is inadequate and insufficient knowledge, because you have knowledge you should share. I think that is helpful, because if you look at all WHO reporting style or international style is based on the expression level, not on percentage. But if somebody insists, yeah, sure, why not? It should be included. Then you can include. For me, if particular expression or the interpretation based on percentage, then it is important. For example, CD49D in CLL, we call it positive as per the criteria. If they are more than 30%, then it is prognostically significant. Then the percentage becomes important. For example, in CRF2, we have standardized, and the European data says fine tuning that if you use more than 10%, they correlate with statistics and molecular very well. So then use cutoff of 10%. Here the expression level doesn't matter, percentage are important. But otherwise, for common markers, expression is important. But if your clinician is comfortable with percentage, I guess you should give both then.
So I think we'll take two more questions. And as I promised all the people who have asked MRD question, we'll have a talk soon on MRD, and we'll intimate you when the MRD is going to be taken by Prashant. So people have asked the question, you've covered malignancies very well. There is a question on how do you differentiate between ETP-ALL and T-myeloid, and what are the features of near ETP-ALL?
Yeah, I think this is very good question. I wanted to cover it earlier, but I knew that this question is going to be, so I thought otherwise also I'm going to discuss. Yeah. Okay. Now, see, ETP is early thymic precursor or early T cell precursor, which comes from the first study when the St. Jude has published this study. They published from the 9 or 11 cases. They found that there is a TLL which has typical gene expression, and the phenotype was matching with earlier precursors like cortical or thymic. If you look at the thymus T cell maturation, it correlates with the earliest precursor of T cells. What are those T cells? What is the phenotype? These are 7 positive, 34 positive, but the CD5 is absent in those T cells. CD1A was absent and CD8 was absent, because CD1A, 5 and 8 comes later during the maturation process. Okay, when it comes at the cortical level of thymocyte. Now T cells, when the T cell is mature, we categorize, we correlate with them with their level of expression at the time of their maturation sequence. For example, if you go to the EGIL classification, it was also like that: prothymic, cortical, postthymic, like that, post-cortical or medullary. That was the classification, type 1, type 2, type 3. So based on that, if a TLL, when we say TLL, cytoplasmic CD3 is positive. Okay, when a TLL meets 3 criteria, I am going to enumerate 3 criteria: absence of CD5 or weak expression of CD5, weak or absence. When I say weak, we can quantify 10 times weak. So when we compare the expression level with normal lymphocyte CD5, it is 10 times weaker, or less than 75%, less than 25% only are positive, 75% are negative. These are the weak expression, definition of weak. So CD5 weak or negative CD5, that is one criteria. Then absence of CD8 and CD1A, 8 and 1A, both should be absent. That is second criteria. Third criteria is criteria of immaturity. That is, if the marker of immaturity like CD34 or HLA-DR 117 positive, or myeloid markers like 13 and 33 is positive, then, so these are the 3 criteria. Criteria 1, CD5 weak or negative. Criteria 2, absence of CD1A and CD8. Criteria 3, presence of blastic marker like 34 or DR, or myeloid marker. If these criteria are met, then we call ETP-ALL. Now, what is near ETP? Near ETP, again, it is more recent. COG first defined it by COG, they call as near ETP. That means by genetic expression wise, the ETP-LL is same ETP, like the gene expression is similar to that ETP, but CD5 is no more dim. It is normal expression, moderate expression. They call it is near because it's very close. The immunophenotype is very close to ETP. That's why called as close to ETP or near ETP. Okay. Now, if you look at the recent publication from 2019, Hematologica publication from European group, they said if you have CD4 expression, even the CD4 is negative expression, instead of CD5, you take CD4 negative CD4 expression and call them all ETPL. I guess this paper is little confusing, but makes sense because CD5 absent or positive present, the genotypically as well as prognostic wise it is same, because only the expression level difference we define it is near ETP and ETP. But if the CD4 is negative, genetically it is same, prognostically it is same, so there is no point using CD5. But because it is study COG and big groups as already explained, so we are using those terminology, ETP and near ETP.
During
No, go ahead, Prashant. Go ahead.
Yeah, so that is how we differentiate between ETP and near ETP. But only thing is that the prognostically they are same, especially in adult. In pediatric, many groups have shown replacing prednisolone with dexamethasone, the outcome is same. Most important point of ETP-LL is the clearance rate is very slow. So almost 90% of ETP-LL will be MRD positive.
Thank you, Prashant. I think you need to come back again for the next session, one more session on flow, and we'll intimate everyone when it will be. There are several questions, some of them on quality control, so which is definitely beyond this session. So we'll request Prashant to cover all these aspects when he's coming for his next class on MRD. So thank you, everyone, and thank you for sparing that much time. And Prashant, it was just awesome. I have no other word. Thank you so much. Thank you. Thank you, everyone.
I would like to also thank you, everyone, for patiently heard this long talk and for their precious time. And thanks to you again and Vikram sir for giving this opportunity.
Thank you so much, Prashant. Yeah, wonderful. And clearly we need more talks from you as a group.
I would be glad. Thank you, sir.
Okay.
Thank you. Thank you.